Hello and welcome to the video. Today I'm going to be talking about understanding diabetes, specifically diabetic ketoacidosis and insulin therapy, with a focus on the pathophysiology and the clinical application. So without further ado, let's get right into it. Diabetes mellitus, or simply diabetes, is a metabolic disease characterized by chronic hyperglycemia, which in the long term can cause a range of microvascular and macrovascular complications, including retinopathy, peripheral neuropathy, and nephropathy in terms of the microvascular complications, and coronary artery disease leading to acute coronary syndromes, cerebrovascular accidents or transient ischemic attacks, or peripheral arterial disease in terms of macrovascular complications. Diabetes is typically classified into type 1, 2, or 3C diabetes. But ultimately, diabetes is a problem with insulin. On one end of the spectrum, we have insulin resistance, which is the hallmark of type 2 diabetes. On the other end of the spectrum, we have insulin deficiency, which is the hallmark of type 1 diabetes, if it is due to autoimmune-mediated destruction of pancreatic beta cells which normally secrete insulin, which typically occurs early on in the patient's life. In contrast, insulin deficiency can also be acquired through chronic pancreatic disease, such as pancreatitis or pancreatic malignancy, and this form of insulin deficiency is known as type 3C diabetes. While the distinction of type 1 and type 2 diabetes generally means insulin deficiency and resistance respectively, it is important to note that in type 2 diabetes, because of having insulin resistance, there is a need for supranormal insulin secretion in order to get the same physiological effect. Over time, this can lead to the pancreas fatiguing, so to speak, which will lead to a reduction in insulin production. And so, in end-stage type 2 diabetes, even though insulin resistance is the initial primary pathology, over time, insulin deficiency becomes the predominant problem, which is why in end-stage type 2 diabetes, patients can still present in DKA or diabetic ketoacidosis, and patients at this end stage often need insulin therapy. In contrast, in type 1 diabetes, where there is insulin deficiency from the outset, insulin therapy has to be initiated at diagnosis. Now that we understand this diabetes spectrum in terms of insulin resistance on one end and insulin deficiency on the other, we can move on to talk about the normal functions of insulin in maintaining glucose homeostasis. Our body has an amazing mechanism to be able to maintain our blood glucose level at a stable range of around 4 to 7 millimoles per liter, as we need glucose to be constantly delivered to all the cells in the body to be able to undergo metabolism to produce ATP for cellular processes. We can't have our glucose levels to be too low because this will compromise metabolism, and we can't have our glucose levels being too high because this will create osmotic shifts and the vascular complications of hyperglycemia seen in diabetes. This process of glucose-dependent insulin secretion occurs at the level of the pancreatic beta cells, also known as the islets of Langerhans. When there is a spike in the glucose level, for example, after a meal, there will be an increased amount of glucose that enters the pancreatic beta cell via this transporter here known as GLUT2. This glucose is then metabolized into ATP that is used for cellular functions. However, ATP also has an inhibitory function on this ATP-sensitive potassium channel shown here, which is flanked by a sulfonylurea receptor. The presence of increased amount of ATP therefore inhibits this channel, which leads to less potassium being able to exit the cell, and therefore an increased amount of potassium within the cell. This subsequently leads to membrane depolarization, which therefore allows the L-type calcium channels to open, which leads to an influx of calcium into the cells. The increased intracellular calcium mediates insulin granule exocytosis, which releases the preformed insulin in these granules out into the bloodstream. And so you can see from this mechanism that insulin secretion is dependent on glucose, or is glucose responsive, such that when there's a spike in glucose, because of this mechanism, there's a subsequent spike in insulin production as well. The role of insulin is to then unlock these GLUT4 channels to allow glucose to then enter cells of the body. For example, muscle cells, which obviously need a lot of glucose and subsequently ATP in order to perform its function. Via the same mechanism, insulin can help glucose enter adipose cells or fat cells, which can then metabolize the glucose into fatty acids and ultimately triglycerides to store as an energy resource, which can be released back in the bloodstream to mediate ketogenesis as an alternative fuel source in times of starvation where glucose is not readily available. So you can see that in this normal functioning system, whenever there is a spike in the glucose level, there will subsequently be a spike in the insulin level, which will then drive any excess glucose in the blood into cells, which will either be used or stored away as fuel, which will then maintain a stable blood glucose level. In type 2 diabetes, when there's insulin resistance, you can see that if the insulin is not able to activate GLUT4 as well as normal, there will be less glucose getting into the cells, which means the glucose level in the blood will be increased. The pancreas can compensate, so to speak, by increasing to a supranormal level of insulin to still drive an appropriate amount of glucose into the cells to maintain a stable blood glucose level. But you can see that over time, the pancreas will start to decompensate, so to speak, and so there will be reduced insulin production and therefore an increased glucose level, which will then need treatment, whether it be with oral hypoglycemic agents or insulin, or the newer injectable treatments. To go over type 2 diabetes treatment briefly, there are many different treatments which ultimately all lead to a decrease in glucose levels. Traditionally, the first-line treatment has always been metformin, which has a complex mechanism but ultimately enhances metabolism to increase glucose utilization and decrease gluconeogenesis, which results in less glucose reserve being released into the bloodstream. Then there are the sulfonylureas, for example, glycoside, which act by binding to the sulfonylurea receptor, which flanks the ATP-sensitive potassium channel and induces the closing of that channel, which effectively leads to an increased amount of insulin being produced. But because sulfonylureas work by essentially constitutively activating insulin secretion, it has one of the highest hypoglycemia risks out of all the available treatment. Then there are treatments which act on the incretin pathway, which augment the levels of endogenous incretins, namely glucagon-like peptide 1 or GLP-1, which has the function of being able to enhance glucose-dependent insulin secretion and increase satiety. These incretins are naturally secreted following the ingestion of food, but their levels can be further increased by taking dipeptidyl peptidase 4 or DPP4 inhibitors, which are the gliptins. Furthermore, GLP-1 agonists or the glutides can be given as subcutaneous injections. And lastly, there are the SGLT2 inhibitors, which reduce glucose reabsorption at the level of the nephron and therefore allows for more glucose to be excreted through the urine to lower the blood glucose that way. But with increased glucose in the urine, there is a higher risk of urinary tract infections and yeast infection. And because it is effective at removing glucose from the bloodstream, patients who are on SGLT2 inhibitors who develop ketoacidosis can present without a hypoglycemia, known as euglycemic ketoacidosis. SGLT2 inhibitors have a relatively low risk of hypoglycemia because the degree of glucose reabsorption in the nephron is dependent on the degree of glycosiuria, and so if patients have a relatively normal blood glucose level, there will be relatively less glucosiuria, and therefore inhibiting SGLT2 in this situation will have less glucose losses through the urine, which will mean that the blood glucose level will not drop significantly. So now that we understand the mechanisms behind glucose-dependent insulin secretion and insulin-dependent glucose utilization under normal circumstances, we can go on to talk about what happens in insulin deficiency and DKA, as well as in a starvation state.